This PET image, the patient presented with that image, there's a flat lesion at the base. So what is missing, Dr. Kalul, in very 2 lines, sir?
Now here, I am not able to tell the bladder wall involvement at all. I have no role here.
Okay. So again, so that is for T stage, sir. So what are the limitations of PET for T stage? Very short, sir.
Yeah, because there is such a avid accumulation of urinary activity there, we cannot tell anything about T1 and T2. We have a role. Suppose when you are doing this PET scan as a metastatic setup, in N and M staging only we have a role. For T stage, please don't use this.
Okay, sir. So we have some Indian data that from PGI, early dynamic is better, has better sensitivity than delayed. So these are some Indian data. And non-fluoride agents, many have been used, but they are not as popular as FDG.
Yes.
So for T stage, as sir told, there is no role. Last case, again a patient with hematuria, now CT, suggestive of light lateral wall 4 centimeter tumor with an enlarged external iliac node. TURBT was done, biopsy is height grade TCC with LVI, muscle is free. No muscle invasion even on second look TR. Now what to do next? Should we treat at a localized disease as a loco-regional or investigate further? One answer, Dr. Sir.
When you have a suspicious node there, it is always better to consider a PET scan. Because the N and M staging is definitely better than...
So you suggest a PET scan. Dr. Palak, you have some other opinion? Yeah, that's it. So what investigation would you suggest? Now an MRI, a PET CT or biopsy of the node? What is the sensitivity of as we all know, MRI and the CT scans, the diagnosis of node are based on purely on the size of the node.
So I wouldn't recommend an MRI at all. Okay. Completely no. PET and biopsy, it would depend on staging versus confirming. Okay,
so we did a PET, as the panelist said. We found this lesion. Sir, can you read this for us? Or you need some additional information?
There is a metabolically active node there in obturator nodal station or external iliac. And CT scan, if you show that, usually it will be there. The PET will make you to see the node better, okay? And because sub centimeter node may be passed on as normal, but here even 5 millimeter node or 8 millimeter node, if it is active, you have to view it with suspicion.
SUV max was 3 and size was 1 centimeter. Yes. So what is the importance of SUV max, sir?
Here SUV has lot of problems, okay? You just take it for a subsequent follow-up. Very high SUV will always tell that it is an aggressive disease, but something hovering around 2.5 to 3.5 or 4 or 5, you better consider a biopsy. We don't want to attribute anything in that. It may be sometimes because of inflammatory pathology also.
Okay. Last 1 minute, sir.
Yes, sir. So again, now we have evidence that the sensitivity and specificity of PET for diagnosis of lymph node is as good as an MRI. So now, as we talked about the threshold of the PET, we have a very beautiful study. It's a prospective study in which the patients were pathological nodes were considered if SUV max was more than 4, if the size was more than 1, and if it was between 8 to 10 and SUV max more than 2, then they were considered. Although the accuracy was 84% as compared to normal PT, only 5 patients were additional, which was not statistically significant. So with this available literature, I don't think doing a PET CT is going to change at this stage. Do you expect a change in management by adding PET, and what percentage change would be significant?
There are not many studies regarding the bladder cancer, but as a thumb rule, in all malignancies, around 30% of the cases, it will change your management when you add a PET.
So, sir, we are running short of time. Last slide.
So you have run out of time.
I'm sorry. So, if PET causes a change in more than 10% cases, then it has to be recommended as a routine. So, with this, I like to summarize my talk. Use of MRI for differentiation between T1 and T2 has a very strong evidence, and it can be used in routine practice. Use of PET CT for local staging is not at all recommended. Use of PET CT for lymph node staging has a weak evidence, and decision is to be individualized. And unless contraindicated, CT scan remains the investigation of choice for staging of biopsy-proven MIBC. And with that, thank you for patient listening. We are open for talk now. Any questions?
Thank you, Dr. Keval Patel, Dr. Kumar Kallur, and Dr. Palak Popat for excellent panel discussion. We move on to the next topic, which is clinical impact in India of molecular subtyping of urothelial carcinoma. And I invite Dr. Divya Midha, who's a senior consultant in the Department of Oncopathology at Tata Medical Center, Kolkata. Madam, you have 8 minutes to conclude your talk and then 7 minutes for the discussion. I'm sorry I'm being ruthless, but that's my time and that's what I'm here for. Sorry for that.
Good morning, everyone. At the outset, I would like to thank the organizers of Sogocon 2023 and for inviting me here and also for giving me this difficult topic, clinical impact of molecular subtyping of urothelial carcinoma. I have removed India. I'll touch on that in a bit. So the majority of the audience today are clinicians and majority are surgeons, but if I ask them how will you subtype bladder cancer, they're going to say non-muscle invasive and muscle invasive bladder cancer. But we also know that non-muscle invasive bladder cancer is a heterogeneous disease consisting of low-grade, high-grade, varying proportions of recurrences, progression, different responses to BCG therapy. And muscle invasive is definitely an aggressive tumor which requires radical prostatectomy and pelvic lymphadenectomy, usually preceded by neoadjuvant chemotherapy. And even this group does not sometimes respond to the NACT. But even though the pathologists in this audience are a minority, I know 100% of you will agree that pathological typing and parameters are the core. We as pathologists should accurately tell you the grade, low versus high, the stage, TA versus T1, T1 versus T2. We should be able to substage T1 in today's day and age. We should be able to accurately tell you whether CIS is present or not, there's LVSI present or not, and we should be able to identify pathological subtypes. And there's a standardized way of reporting using CAP, WHO, and the ICCR guidelines. And as you see, these pathological parameters have crept and are ingrained into the risk stratification of non-muscle invasive bladder cancer. And the recent edition of WHO emphasizes on us identifying the urothelial carcinomas with divergent differentiation because they have treatment implications. And of course, we should be able to correctly identify histological subtypes, particularly micropapillary plasmacytoid, sarcomatoid, because they are aggressive and they need upfront cystectomy. So, in this current era of precision oncology, we need to integrate clinical data, pathological findings, and also try to understand the molecular underpinnings of a tumor. Now, the urothelium, we need to understand the equilibrium of the urothelium. The stem cells of the basal aspect is more specialized than the luminal aspect, that is the umbrella cells and the intermediate cells. Bladder cancer has a divergent pathway of development. We have the FGFR or mutation, HRAS mutation, or the papillary pathway highlighted in shades of green, and the TP53 mutation pathway, which is the non-papillary pathway highlighted in shades of red. So when we try to molecularly subtype tumor, what are we doing? It's rather complicated and daunting. We are cataloging the entire messenger RNA expression and the DNA alteration, performing a cluster analysis of the different genes based on the gene expression levels, and these clusters are then validated by DNA, PCR, and IHC technique. Yes, it's quite difficult. And that is why the work on molecular subtyping in bladder cancer happened quite recently. The first work was done in 2010. And subsequently, there were many classifications which followed, but both insisted on two subtypes, the luminal and the basal, and that was in common to all the classifications. So the TCGA, the first one, was published in 2014, and it consisted of 4 major expression clusters. And the second TCGA came in 2017 with 5 subtypes, and thereafter there were 6 classification systems, and there was a dire need to get into a consensus. And therefore, we have the Coumad's classification, who kind of reconciled all this published data and published a consensus molecular classification of muscle-invasive bladder cancer. There were 6 subtypes. The luminal had 3, luminal papillary, luminal non-specified, luminal unstable. There was a large chunk, the basal squamous, and a small component neuroendocrine, and of course, a stroma-rich. Now, the luminal papillary had the FGFR3 mutations. It had a papillary histotype. The luminal unstable had P53 ERCC2 mutations and was aggressive, more aggressive than the luminal papillary. The basal squamous was a large chunk, 35% with P53 RB1 and behaved quite badly. And the neuroendocrine, though a small 3% block, it also had the TP53 and the RB1 mutations and behaved worse. So these subtypes, ideally, according to this paper, are supposed to have distinct clinical outcomes, pathological features, immune microenvironments, patterns of gene expression, resulting in different potential responsiveness to treatment. For example, the luminal type, papillary type should be responsive to the FGFR3 targeted therapies, and some of them, I believe, are in practice, and the luminal non-specified to NAC and immunotherapy, the luminal the unstable to radiotherapy, immunotherapy, and so on. But is this true? The consensus was supposed to consolidate the previous work. It was supposed to be a reference for future studies. It should highlight different oncogenic mechanisms. It should also give us some information about the infiltrate of immune cells and stromal cells. But most importantly, it should enable testing and validation of some predictive markers which can be used in the future. But then came this paper by Warwick et al., which said that there was intratumoral heterogeneity by molecular subtypes, which meant that there was overlapping of molecular subtypes within a single tumor. There were papers which suggested that molecular subtypes determined by these global gene expressions showed no association with the cancer-specific survival rates. So while this provided useful prognostic and predictive information, such tests are very complex, they are time-consuming, and they are expensive. They are not easily accessible, even in present times, and thus their clinical implementation is not currently entirely feasible. But Dr. Borges says that IHC is not at odds with molecular pathology tests. IHC is a molecular test that is fully integrated into a routine histopathology lab. And the 3 surgical pathologists or 4 that I can see in this audience are all molecular pathologists, because DNA translates to RNA and RNA translates to protein. Therefore, we can use IHC surrogates as for various molecular subtypes, and they can be implemented into the pathology workflow because IHC is universally acknowledged. It's a standardized ancillary method. It can be used in a vast majority of pathology laboratories. They are readily accessible, inexpensive. You can visualize single cells, allowing it to be distinguished, the signals from non-tumor versus tumor cells. It does not require fresh tissue. It can be done on FFPE specimens and also on archival tissue. So here's a host of basal markers, which I showed you from my previous diagram, and a host of luminal markers, IHC markers, which can be applied, and you can therefore distinguish the basal and the luminal types. But this study in 2017 used 14 markers, and they noted some divergence and convergence phenomena. Tumors belonging to the same IHC subtype clustered apart from the mRNA analysis, and tumors with different phenotypes co-clustered at the RNA level. So there's confusion. So instead of looking at so many markers, people started looking at a limited panel. So Guo et al. Studied GATA3 as a luminal marker and CK56 as a basal marker, and they could subclassify the molecular types in over 80% of the cases. However, it remained unclear what to do with the double negative and the double positive. Similarly, Cho et al. Also studied CK56 and CK20, but they also studied P53, and they found that these muscle-invasive bladder cancers were consistently resistant to neoadjuvant chemotherapy. Then 3-panel IHCs were studied, CK56 and GATA3 to distinguish the basal and the luminal type, and a third marker, P16, was added. If it was P16 positive, it was genomically unstable, and P16 negative was urothelial-like. Then work was done on the non-muscle invasive bladder cancers. Work was done on carcinoma in situ. Yes, I'll be hurrying. In the Indian context, this is the paper from the Rajiv Gandhi Center, which studied 4 markers, CK56, CK20, CD44, and EGFR. This is the first and the only paper. The rest is all thesis topics, I believe. And 47.3% cases were basal, 42 were luminal, and 10% remained unclassified. And they found that the overall 1- and 2-year survival was more in the luminal subtype than in the basal subtype. So what are the limitations? Assessing this clinical impact of the differences between gene expression and IHC-based subtyping is difficult. if you use TMAs, there will be a problem of tumor heterogeneity. Also, these are mixed cohorts. It's a mixture of CIS, TA, T1 disease, low grade, high grade, and this will lead to confounding results. The selection of the optimal IHC panel is difficult. Determining the cutoff of the staining is also very difficult. Now, I like pink, so I love my HNE. It's faster TAT, cheaper, precise, but there should be a standardized way of reporting the CIS, LVSI, low grade, high grade. We should be able to tell you stage, substage, and the histotypes. Now, molecular and IHC-based typing does provide information about tumor biology, progression, prognosis, and treatment, as I have shown you earlier. Molecular is, however, daunting. The heat maps are confusing, they are complex, time-consuming, and expensive. Accessibility is the issue, it's a static research. There are problems of intratumor heterogeneity. It does not give us information of LVSI, CIS, and stage. What the future holds is artificial intelligence in surgical pathology, whole slide analysis rather than TMAs, single cell, high throughput sequencing, mass spectrometric analysis, etc. And again, quoting Dr. Borges, I'll say, histology-based proteomics, Madam insists, is what the future holds, where the pathologist will be able to project on a screen, map expression levels of any marker. Exponential growth of information will be extracted from smaller and smaller tissues. Computer-based algorithms will require bioinformatics in every lab. Technologists will evolve into robots. Conferences like this will be held in cyberspace. And she insists, and to an audience full of clinicians, pathologists hold the key to the real and virtual world. So I hope in order to guide adjuvant chemotherapy, targeted therapy, and immunotherapy, these molecular classifications will become an important complementary approach to the traditional pathological classification, and we will enjoy a Barbenheimer. Thank you so much for your patient hearing.
We have 4 minutes for discussion.
Any questions, Borges, madam?
Ma'am,
Any thoughts?
excuse me,
My
ma'am.
thoughts
I
are
have a
right
question.
there. No, I think that it's too early to talk about a molecular classification of bladder cancer, which will be used in the clinic. I think that we have a long way to go, but what is important is the understanding when you do a molecular study or an immunohistochemistry study or whatever study that is not an H&E, what it helps you to do is to understand why the H&E actually segregates tumors into different types. That